So for our next presentation, it's my pleasure to introduce Dr. Kate Bentley, whose talk will focus on psychosocial interventions.
Hi everyone, thanks so much for having me today. It's really thrilled to be here and looking forward to the rest of our discussion. Thank you so much for the speakers so far. So I'm very excited today to share a little bit with you all about psychosocial interventions for suicidal thoughts and behaviors, or CBTs. So in terms of my agenda for my talk today, my goal is to give you a broad overview of key types of psychosocial interventions for CBTs to date. I'll briefly mention the evidence base for key approaches, and then I'd like to end with a few questions along the lines of where to go from here, which I hope we can talk about more throughout the day. So in terms of the types of psychosocial interventions that I'm going to address, I'll cover crisis lines today, brief contact interventions, safety planning type interventions. I'll also go over key forms of psychotherapy and more recent apps. And I'll also talk a bit about multi-level systems approaches. These generally range from less intensive to more intensive. What I won't go over today are a couple of things we've already heard a lot about, means safety and restriction efforts. I also won't go over gatekeeper training and public or provider education efforts. And I also won't talk about more just-in-time interventions because I want to tee that up for Dr. Knott. So crisis lines. Crisis lines offer free, confidential, 24 hours a day, 7 days a week support from a trained crisis counselor for people who are in emotional distress. You may have heard or seen recent headlines about 988. 988 is the recent network of crisis centers, so it now spans 200 local and state crisis centers. It was formerly the Suicide Prevention Lifeline. 988 used to be a 10-digit number. Just a few months ago, it switched to a 3-digit number with the goal of really increasing access to in-the-moment mental health support when people need it all across the country. So instead of people now needing to remember either a 10-digit number or the local numbers for specific crisis centers, they can call 988 and almost instantaneously receive support from a trained crisis counselor. What about the empirical support for crisis lines? Generally, the research we have to date shows that people tend to report that pre-post phone calls with crisis lines or text-based chats, they tend to experience changes, reductions in their levels of distress and suicidal thoughts. So this is good news. However, we have pretty limited post-call outcome data so far. So this research is hard to do, meaning do people who call the crisis line, are they less likely to go on after having a crisis call to make a suicide attempt or die by suicide? This research is really hard to do because of the confidential nature of these calls. That said, there's more and more work ongoing, especially in the VA, to try to link up crisis line data with electronic health record data. And I think with 988 and the expansion of 988, we're likely to see more rigorous research on crisis lines over the coming years. So now I'll talk a little bit about brief contact interventions. Brief contact interventions involve supportive messages that express care, concern, or offer re-engagement into care for people who are at risk for suicide. They usually come in the form of letters. You see an example of this here, which I'll talk more about in a moment, texts and calls. And these messages generally don't require a response from patients. Brief contact interventions are often used during periods of really high risk for suicide, namely after a hospital visit or hospital discharge, or even after missed appointments. And the idea behind these messages is pretty simple, that people who are at risk for suicide often lack a feeling of connection, they may experience loneliness, which is a risk factor for suicide. So being reminded that they're cared about, expressed concern about from a provider or another member of the clinic staff potentially can be quite powerful. Another really appealing thing about brief contact interventions is that these are very low cost, they're very scalable. They don't necessarily need to be from a trained mental health provider, they can really be from anyone. So I'd like to talk a little bit about a very seminal study, the first study of caring contacts done by Dr. Jerome Motto. You can see an example here of a letter that Dr. Motto sent. This was the first big caring contacts trial where Dr. Motto randomized 800 patients after receiving hospital care, and then these people did not stay in engaged care, to either receive caring contacts by letter 4 times a year over 5 years or not receive caring contacts. The effects were pretty striking in that every year during the follow-up period, people who got caring contacts were less likely to die by suicide than those who did not. That said, the effects did diminish over time. Given how striking these findings were over the years, it makes a lot of sense that a number of different teams have tried to replicate these findings or test caring contacts in different formats. Most recently, Dr. Kate Comtois conducted an RCT of caring text messages, our 21st century equivalent of caring letters. And this was in soldiers and Marines, just over 600 people who visited an ED. Dr. Comtois' results were more mixed in this trial. She found that caring text messages did have a significant effect on suicide attempts in comparison to the control, but it did not reduce levels of suicidal ideation or ED or hospital visits for suicide-related reasons. Very recently, a meta-analysis came out of 6 randomized controlled trials for caring contact interventions, and similar to the Comtois trial, it did show inconsistent effects. So overall, it appears that caring contacts may have, at least from the research we have to date, a small protective effect against suicide attempts, but not so much completed suicide or ED or hospital visits for suicidal thoughts and behaviors. That said, given how low cost, how scalable these approaches are, they are generally recommended for healthcare systems, especially for these periods of high risk, like after a hospital discharge. I'll now talk a little bit about safety planning type interventions. Safety planning interventions are generally delivered in a single session, usually with a healthcare provider, pretty brief, lasting about 20-30 minutes. The goal of these interventions, as the name would imply, is to plan for future suicidal crises. Key types of safety planning interventions, and those that have received the most research and empirical attention to date, are the safety planning intervention developed by Drs. Barbara Stanley and Greg Brown, and then also crisis response planning by Dr. Craig Bryan. On the right here, you can see an example of a safety plan. This is the Stanley Brown safety plan template, and essentially what this would involve is a patient with their provider or another trained person sitting down and identifying the specific personalized coping strategies that tend to, per their report, work for them in terms of writing out suicidal urges before they act on their suicidal thoughts. So a safety plan is supposed to be used in stepwise format. People might start with the internal coping strategies and work up to more intensive professional resources. After a safety planning intervention, which is often done in an ED or acute care setting, a patient would leave with this safety plan, have it accessible that they could use during these moments of really high risk in the future. So what about the evidence base? Dr. Barbara Stanley and her colleagues did a large RCT of over 1,600 patients who presented to an ED and randomized them to either receive safety planning in the ED plus follow-up via phone over, I believe, a 6-month follow-up period, or no safety planning, no phone-based follow-up. What they found is that overall safety planning did result in a reduction in the rate of suicide attempts over the 6-month follow-up period. And then recently, a meta-analysis of other safety planning trials, this was 6 trials to date. You can see the risk ratios across these different studies on the side here. Even though there was, even though there's a pretty wide range of these risk ratios, overall pooled effects did show that in general, safety planning interventions lead to about a 40% reduction in the risk of suicide attempt. That said, safety planning interventions from this meta-analysis, do not appear to significantly reduce suicidal thoughts in comparison to a control. That said, we wouldn't necessarily expect it to, given the emphasis on writing out a suicidal crisis, not necessarily targeting the drivers of suicidal thoughts and behaviors. All right, so we've covered a few of the less intensive psychosocial interventions, and now I'm going to talk a little bit about those a bit higher up on the intensity scale. So first, cognitive behavioral therapy, or CBT. CBT refers to generally multiple sessions of psychotherapy with a trained provider. This can be done in individual sessions, one-on-one or in group, also in person or increasingly over telehealth. CBT, as opposed to some other forms of therapy, is generally time limited, maybe 10, 20 sessions, something in that range. It's structured and it focuses on teaching people cognitive and behavioral strategies for managing suicidal thoughts and behaviors. There have been a few versions of CBT that have been developed specifically to target SIPBs. And I want to mention that there are many, many CBT protocols out there for targeting a wide range of mental health conditions that commonly co-occur or may be risk factors for SIPBs. CBT for depression, CBT for anxiety, CBT for PTSD, substance use disorder, the list goes on. That said, current consensus in our field is that in order to be maximally effective for suicidal thoughts and behaviors, therapies really need to include an explicit emphasis on SIPBs. So not necessarily treating someone's depression or anxiety and hoping that SIPBs will reduce as a result. So in terms of CBTs that specifically target SIPBs, we have CBT for suicide prevention, also cognitive therapy for suicide prevention, brief CBT, and then we also have dialectical behavior therapy, or DBT. I will note that DBT is a bit more intensive than these other forms of CBT. It's much longer, tends to last about a year, at least when it's delivered in its full package format, and comprises several different modes of therapy. Group sessions to learn skills, individual sessions, and also phone coaching. So what about the empirical support for CBT? I want to briefly highlight a seminal study led by Dr. Greg Brown that compared, this was done about 15 years ago, so a bit old now, that compared cognitive therapy for suicide prevention for 120 patients who presented to an ED after a suicide attempt versus usual care alone. Here you can see the probability of remaining re-attempt free over time. So they used an 18-month follow-up period. Cognitive therapy was delivered exclusively in outpatient settings, so after patients had left the hospital. You can see here that the cognitive therapy group and usual care are pretty nicely separate. Those who received cognitive therapy were 50% less likely to make a suicide attempt than those who received usual care alone. Interestingly, the authors of this study did not see a significant effect on suicidal thoughts. This is an important finding that I'll get back to in a moment. Over the years, there have now been many trials on various forms of CBT or DBT for targeting SIPBs, and overall from recent meta-analyses, we see that these treatments generally do reduce the risk of suicidal behavior, even if overall effects are fairly small, but they don't consistently reduce suicidal thoughts. All right, so I'm going to talk a little bit now about iCBT, or internet-based CBT and apps. Many of you are well aware that smartphones are now ubiquitous in our society, right? Everyone has a smartphone. It follows that, most people have a smartphone. It follows that we, as a field, are very interested in using these smartphones to better bridge the access gap, right? Many of us are aware of the fact that we will never be able to meet the need in terms of those who require psychiatric care or at risk for suicidal thoughts and behaviors. There's simply not enough adequately trained providers. So many, understandably, have been interested in whether we can leverage smartphones and internet to deliver components of evidence-based psychotherapies like DBT, CBT, to patients directly via their mobile devices. That said, are these treatments effective for SIPBs? There have been a number of trials in recent years and a few meta-analyses, and overall, there's a lot of heterogeneity and variability in these findings, but overall meta-analyses have included that digital therapies for SIPBs, such as iCBT and apps, do tend to show promise for suicidal thoughts. That said, we really need a lot more rigorous research, and especially rigorous research that targets treating suicidal behavior. I want to take a minute to highlight a pretty thought-provoking study that came out just earlier this year. This was led by Dr. Greg Simon and his colleagues. This was a very large, pragmatic, randomized control trial of over 18,000 patients with frequent suicidal ideation who were recruited via the medical record. What Dr. Simon and his colleagues did was randomize people to receive 2 low-intensity interventions, which are based on evidence-based practices. One was a brief online DBT-based skills training program, and one was care management, which involved systematic follow-up, contacts, risk assessment, etc. And they compared these to usual care. So in this figure, you see the self-harm event rate over time by treatment condition. Here you can see that those who received the DBT, or who were randomized to receive the DBT skills training component, had a higher incidence of self-harm events during the follow-up period than those who received usual care alone. Also, you can see here that care management and usual care really hang together. Care management did not do better than usual care alone in terms of reducing the risk of self-harm events. These findings were surprising and sparked a lot of debate and controversy in our field. There are a few pretty noteworthy characteristics about this study that need to be taken into account when we're interpreting the findings. For example, engagement with these interventions was pretty low, uptake was low, also just some of the strategies in terms of recruiting patients from the EHR, they're important to consider. That said, these findings are compelling and certainly offer some food for thought for us as we, as a field, are thinking about how can we take approaches that have been shown to provide empirical support for reducing SIPs and translate them into lower intensity, more easily accessible interventions. All right, very briefly now I'll talk about some psychotherapy and CBT-adjacent approaches. These are all forms of psychosocial interventions for SIPs that are very similar to CBT, but not exactly the same. So the first we'll talk about is the Collaborative Assessment and Management of Suicidality, or the CAMS protocol. This was developed by Dr. David Jobs. This is a 6 to 8 session therapeutic framework that offers clinicians a way to directly address suicide risk. The emphasis is on developing a stabilization plan for patients and coming up with effective strategies for coping. One really nice or attractive thing about CAMS is that it's very flexible. It can be used in adjunct to other services and works across any other therapeutic modalities. So the idea is this isn't a specific form of therapy per se, but it really offers a framework for clinicians to be directly targeting SIPs with their high-risk patients. Our recent meta-analysis, this was of 9 trials I believe, did show that CAMS significantly reduces suicidal thoughts. This was an important finding, given what I was sharing a few minutes ago about the fact that many other psychotherapies have not been shown to consistently reduce suicidal thoughts as opposed to behaviors. Next, very briefly, the Coping Long-Term with Active Suicide Program, or CLAS. This is also an adjunctive intervention that really targets high-risk transition periods, namely after hospital discharge. The CLAS program involves very intensive outreach by a trained provider and multiple therapeutic strategies. It also involves looping in patients' significant others, maybe family members. Overall, there's limited empirical support on CLAS to date, but that said, the evidence we have is promising, and there are numerous studies of CLAS that are ongoing now. And then very briefly, the SIP program, this was developed in Switzerland. It's a 3 to 4 session protocol for addressing patients' recent suicidal crises and giving them effective coping strategies for working to the future. In an initial study of a SIP, there was a pretty striking finding that this intervention appeared to reduce the risk of repeat suicide attempts by 80%. That said, this was a fairly small trial, definitely requires replication, and there's more work on a SIP ongoing now. All right, so the last key type of intervention I'll talk about today before stepping back a bit is multi-level systems approaches. Multi-level systems approaches are broad, resource-intensive approaches for targeting SIPs that span multiple levels, so healthcare settings, schools, media, etc., and also different intervention strategies, many of those that I've talked about today. The idea here is a very reasonable one, that in order to make a real dent in the suicide rate, we need to implement interventions at every level of society and also target the needs of specific communities. One multi-level systems approach that has received a lot of recent traction is the Zero Suicide Quality Improvement Model. This is an example of a multi-system approach for healthcare systems specifically. Very briefly, to share a bit of the empirical support, there was an initial QI evaluation of the Perfect Care Depression Program, which substantially influenced Zero Suicide, but is not exactly the same, that was done in the Henry Ford healthcare system. Initial QI findings of this approach showed that it led to a 75% drop in the suicide rate. These findings appeared very exciting, led to a lot of awards and attention. That said, since that time, there's been a fair amount of criticism of these findings. They may have been overstated, and they really require replication with more rigorous approaches. And there are large studies of zero suicide now ongoing. So I only have a minute left. I'm going to be very quick. I just want to highlight a recent meta-analysis led by my colleague, Dr. Catherine Fox, that came out that summarized the results of all intervention studies for SIPs to date. Dr. Fox and her colleagues summarized the results from over 1,100 unique RCTs and found that the overall intervention effects of all existing interventions for CIDPs are small. This is the same across all different types of CIDP outcomes examined, and also it showed that intervention efficacy has not improved over time, despite the fact that there have been many, many more studies over the course of the years. Very briefly, I'll show this figure which compared different types of interventions and their pooled effects. As you can see here, as evidenced by the overlapping confidence intervals, no one type of intervention appears to be more effective than others in terms of reducing CIDPs, and overall, even the strongest effects are fairly small. So very briefly, in terms of where we go from here, these findings overall are sobering, and I think certainly speak to the need for us to do more work to refine the interventions we have and also develop newer approaches. That said also, and I think we'll talk about this more today, one really interesting question is to better identify what works for whom. When you think about how much variability and heterogeneity there are in people who experience CIDPs and also all the interventions we have, it may not be that surprising that when you give the same intervention to a lot of people who meet only basic similar characteristics, that the overall intervention effects are small. That said, there's a lot of work going on to figure out how we might leverage data that we have to predict for the individual patient who's most likely to respond to what intervention. Also, we need more research on cost effectiveness for the interventions we have and in what context they're the most effective. Again, this is harkening back to the point I mentioned earlier about the access gap and how costly some of our most evidence-based approaches are. Finally, we need to disseminate and implement the current evidence-based approaches that we have. Again, there's this huge access gap. The vast majority of people in need will never be able to access the approaches that we know have been effective. And then finally, just to tee things up for our next speaker, we're also very interested in thinking about how technology might help us to enhance and scale assessments and interventions for CIDPs. Thank you so much for your time.
Thank you so much, Dr. Bentley. So we have time for 2 questions or comments from the audience.
Thank you very much. Carrie touched on this briefly at the end of her presentation, but given the rather substantial protective associations between social integration and suicide, which also seem especially pronounced for participation in religious community, what do you think of what in the UK at least they're calling social prescribing? One could imagine an approach where for those who positively self-identify with a religious tradition, suggesting community participation in that, and for those who don't, suggesting other forms of community participation. It seems like the Papageno effect is real. Should we be encouraging community participation?
Yeah, definitely. That's a great point. And I think that, I'm a psychologist who regularly treats patients. Of course, when we're working with someone who's isolated, who's having suicidal thoughts, getting them engaged in their community and building those social connections is often a primary treatment target. And in the interventions that I've talked about today, that there really is sort of a key tenet of the vast majority of them. Brief contact interventions, right, showing support. CBT, often a component of CBT is working to get people doing more positive activities, engaged in their community. Also in terms of the access gap for mental health providers, I didn't touch on this today, but there's a lot of exciting work going on in terms of peer support, and whether that's online, whether that's in person, and looking at the potential protective effects of having people more engaged with those others who may have lived experience or engaged as part of community. For me, that certainly falls under this idea of a multi-level systems approach, where we might think about many different levels of promoting interventions for CIDPs and also connectedness. That could be done through healthcare settings or via other forms of social communication.
One more question right here.
I'm going to sneak in 2 questions, actually.
Okay.
So, can you talk a little bit about attrition, dropout in these trials? What that is like? I'm just curious. And then after you're done, I'll ask my second question.
Yeah. So the one I'm really thinking of for this is that big Simon study that I showed a few minutes ago. I can't remember the exact statistic, but I think it's something along the lines of only like 39% of people who were randomized to receive that DBT skills training program started it, and then something like 9% maybe engaged in multiple of the modules. In terms of cognitive therapy and these other forms of in-person therapy, we also sort of can see pretty substantial rates of attrition. This is a really big problem when you're treating people who are experiencing very high levels of symptom severity with mental illness and also who are suicidal. And I've talked some today about this high-risk period after hospitalization. One of the reasons that that period is such high risk, at least we think it is that people are pretty unlikely overall to stay engaged in care after they receive intensive hospitalization or programs. So my short answer is that yes, this is a problem, and in addition to better refining the content of the interventions we have, we need to figure out how to keep people engaged, which also I do think underscores the value of these brief single session interventions when you're not necessarily assuming that someone's going to be coming back for more care.
Okay, thank you.
Question
And let me just,
number two.
just quickly, and this probably requires more time for a longer answer, but I'm just curious about your thoughts about the fact that all of these different trials are focused on an array of outcomes, CBTs in terms of ideation, all the way to suicide death, and I'm wondering your thoughts about that and how that might relate to the heterogeneity in findings and the small effect sizes and things of that nature.
Yeah, definitely. So more recently, I think there has been an increasing awareness across these trials of how important it is to look at specific outcomes. So, for example, as you're saying, suicidal thoughts versus suicide attempt versus suicide plan versus suicide deaths. Historically, it was more common to sort of lump all of these phenomena together and say any sort of suicide-related outcome. That said, when you dive into the CBT literature, psychotherapy literature, we do see that there tend to be different effects of these interventions for different types of CBT outcomes. In Dr. Fox's meta-analysis, they did this. They looked across different CBT outcomes, and there were also no differences in terms of interventions that we have. I do think that's a very important thing to do in these trials because we likely will see that certain interventions, for example, like safety planning, are more effective for suicidal behavior than ideation. It's harder to, as we're thinking about these big scale studies, it's much easier to glean information about, for example, suicide attempts, ED visits from very large samples by using healthcare data. That's a little bit more challenging to capture outcomes like suicidal ideation, which can often require self-report from patients, which is costly, tricky to follow people up. So, challenges.